Okay, so this is the issue just about stewardship. I guess while we're all here, rising resistance. I was just talking to a colleague here about when I started in general practice, kids would come in with acne and I'd give them antibiotics and they'd be better 2 weeks later. These days they have 3 months of doxycycline and they're still usually not better, probably because they don't take the doxycycline all the time as part of the problem. But I'm going to talk about isotretinoin as an alternative. So if you haven't had your hands on isotretinoin, it's a wonder drug. So the delayed antibiotics are obviously a solution, but I've done some work on that. 50% of people still pick up their delayed antibiotic, so that's a problem. And in a sense, it's a bit of a con. You're saying, I don't think you need an antibiotic, but you do and I don't. So to keep you quiet, I'll give you a delayed antibiotic. And really, I think we should start saying no. There's lots of evidence that if you give an antibiotic, people are medicalised and they come back wanting really good randomised trial evidence from the UK. If you've got an antibiotic as opposed to not, you're much more likely to come back next time you have a sore throat in the UK, which is a bit different from here.
But I think it could be potentially different in the respiratory tract situation where you really do think it's a virus, and so you're doing the back pocket prescription to placate, as opposed to perhaps some of the new guidelines that may or may not come out around urine that we'll talk about a little bit later, and that's a situation where we think, yes, there may well be a bacterial infection, but the balance is more, are we actually going to step into this bacterial infection and use antibiotics, or are we going to see if the body can manage it on its own? So I think there are the sort of emerging two different ways of looking at back pocket prescriptions.
Yeah. The nice guidelines are just throwing a hand grenade into the field. So.
Yeah, although,
there's the issue of C. difficile, and I was just going to make a comment here just as a take-home message. If you're looking for C. difficile, you have to request it specifically, and it's a different test from the stool culture, because we had a run in our clinic where one of my colleagues was ordering stool cultures thinking she was getting a C. diff, and the patient actually had C. diff and was pretty irritated after about 2 months of pretty horrific symptoms, not getting better, to get the diagnosis. And none of us knew, this was like 20 years ago, none of us knew you have to you put the stool specimen on ice, don't you?
Yes.
It's quite a performance.
But with respect to C. diff, because we don't want everyone to be sending in C. diff specimens with every patient with diarrhea. So there's C. diff is a bacterium, it's in the soil, it can be in our gut, and it can or cannot produce toxins, and it's the toxigenic producing version that can cause very nasty diarrhea. Babies carry toxigenic C. diff, and often in first, second years of life, so we don't like to see requests for C. diff on babies or children, and so I think outside of the sort of older person who's really started to get actively engaged, unfortunately, with medical care, outside of that, in primary care, I don't think there's many times where it is appropriate to be doing C. diff testing. You know, it's obviously different if someone's 25 and has had a bone marrow transplant and they've had a lot of antibiotics. That's completely different. And what we hope is most people in primary care who are reasonably well, I don't think C. diff should be on, something, unless it's really something quite bizarre. But with the older patient who's been in and out of hospital and had a lot of antibiotics and has got diarrhea, that's when you need to think about it, and yes, you need to request it specifically. I
saw an article in the last year where people who'd been in the bed of somebody in hospital who had C. diff were more likely to get C. diff.
Yes. Although it's a big controversial area in infection control, because initially it was thought it was all spread through the infection in the hospitals, but now they realise, because it's everywhere, it's kind of environmental, so people are bringing it in and bringing it out. We haven't seen big problems with C. diff in New Zealand as they have in parts of North America and the UK. But one of the reasons why they think there was a bit of an emergence of C. diff, and I always point these things out because I think as a society we don't think enough about unintended consequences, and this is there's always examples of it. So we brought in the hand gels, and overall the hand gels are a fantastic thing for infection control and keeping ourselves and patients safe, but the hand gels don't work for the spore-related form of C. diff. So it makes itself into a wee spore, and it can live in the environment for ages and ages, and the alcohol hand gels don't kill it. So you actually need to wash your hands properly with soap and running water to get the spores off your hands. So it's just that sort of, you know, we do well-meaning things, and it's not to say that they're not a good thing to do, but there often are unintended consequences, and I think that we can potentially down the line perhaps discuss some unintended consequences around the rheumatic fever pathway as well. So we always just, I think we need to be aware that you do something that you think's good. Nothing is ever 100%. We always have to keep in our minds what is the potential negative downstream effects as well.
The issue of the microbiome, I mean, there's, I must admit, I'd find it very hard to be a researcher of the microbiome. There just seems to be too much going on there.
Yeah, there does seem to be too much going on.
Mental health things. And then the whole issue of probiotics, which actually, do you want to make a comment about probiotics?
The probiotic comment, once I had a GP that told me off actually, because I said, oh yeah, no, I would recommend probiotics, and she said, well, Arlo, they're not funded, and there actually isn't good data, and I went, yeah, okay, that's true. So she was being very professional. I want to think that they work, so I was being, I think there are probiotics that do work, but I think there's loads and loads and loads of different probiotics. There's loads of different conditions that have been tried to be used for. And I think it's just mixing and matching and actually trying to find what works. There is some evidence, for example, in pregnancy and early breastfeeding, the study that was done in Auckland by Edward paediatrician, whose name?
Ed Mitchell.
Ed Mitchell, yeah. That showed reduction in eczema and asthma among these babies where their mums had been exposed to a Fonterra probiotic. So there is, but it's not a panacea. One thing I would say, and it might be something we talk about later around trying to change the culture towards antibiotics, is there is a little bit of evidence that antibiotics make you fat. So it's not fantastic
Stop
evidence,
eating them.
but there is a little bit of evidence around the change in your gut flora. You know, so I think that that's not, you know, there's some quite common side effects that we could discuss, and that perhaps primary care can move into discussing with patients with expectations.
We've dived in a bit deep here.
Okay.
So that's okay.
Come up for you.
So just taking a step back. Okay, so that's just where things are going. They're discretionary, not mandatory. That's a quote from Chris Del Mar, who's a professor of general practice at Bond University in Australia, and he runs the Cochrane Acute Infections Group, of which I'm a part. Of course, acute infections are a big problem in primary care, and that was one of his great lines. And I think with the new BPAC guidelines, shorter courses, sometimes higher doses, seems to be the general theme. And I remember a colleague of mine some years ago, and it was profound, David Hoadley of Avondale, he said, you know, we make up the duration of antibiotics. And I now like going to groups of doctors and nurses and saying, how long, and especially the GP registrars, they're my favourite, how long should you give an antibiotic for? 3 days, 5 days, 7 days, 9 days, 10 days, 12 days, 14 days. And when you think about it, that's how we think as humans. It's uneven numbers till we get to 10, and after that it's even numbers. And everyone sort of cracks up, but that's just how we, you know, it's a 3 day, 5 day, 7 day, 10 day course.
Isn't that interesting?
We make things up.
Rod Ellis Pegley used to always say, how long is a piece of string?
Absolutely. 10 days. Okay, there we go. There are a few things where they're mandatory. We'll talk about strep pharyngitis because I think that's sort of almost got out of control in the public. I think the school program is fantastic. I think the school program has got, if you're going to make a difference, you're going to do the school program. But anyway, we'll talk about that.
That's where we're going to have our scrap.
Okay, some otitis media, pneumonia, and I would make the point, and you just have to remember this, if you look at the otitis media literature, very sick kids don't get into those trials. Yeah. So that's where you have to keep your brain in gear. So they may have a unilateral otitis media, but if they're looking as sick as a dog, then you might want to err on the side of caution. and just to line that up. And most antibiotics are given for viral infections in New Zealand, not bacterial infections. And they're given for symptoms, not diagnosis. Because actually it's pretty hard to make a diagnosis on a lot of these things, you know. We'll talk about sinusitis, which I think is the classic. And, you know, there's very little empirical work on what is bacterial sinusitis.
And if I could make the comment, and I guess when Bruce said earlier, a little bit tongue-in-cheek about your colleague saying that you shouldn't give an antibiotic if you have, unless you've got a microbiological diagnosis. But one of the difficulties in the micro lab and translating that into clinical care, and what you guys do in clinical care, is that the organisms that cause infection in different parts of our body are often the organisms that live in those same parts of our body. And so you will have, so the classic is infective exacerbation of COPD. It's not hard to get someone with infective exacerbation of COPD to produce a sputum specimen. So you think, oh, it'll be nice, and I'll send it to the laboratory, and we get it in the laboratory. After looking at it, we want to vomit. And then, you know, and then we culture it, and then it's like, what does this all mean? Because those, you know, the H flu and the pneumo in the nasopharynx, the airways are abnormal, they're damaged over many years, have been exposed to pollutants of one way or another, and so those organisms are there. And say if it is only a virus, there's a virus that's causing the infection, that's leading to the inflammatory response. They're getting white cells, they're getting the extra mucus, they're easily coughing up a piece of brown, green sputum. We can grow those organisms. Does that actually mean that that's what needs treating? And I think that I quite frankly would like to see 90% of the sputum samples that we receive tossed out the window. Because I don't actually think they're necessarily helpful, and I think in that setting, and it's another area we can talk about with urines as well, is that we may be doing more harm than good by sending that sample off, by producing, because you guys see the sputum and you think, oh gosh, I've got to send it off, this patient's produced the sputum, I've got to send it off. It's that whole needing to do something. We get the sputum, so we think, oh, we better do something with the sputum because we don't want to lose our next contract with the DHB. So we do something, then we grow some bugs. Oh, we better report those bugs because we're not the ones who've seen the patient. And oh well, we're reporting the bugs. We report some antibiotics, and so it goes through the cycle of well-meaning behaviour, but actually it might not be what's best for the patient and for society as a whole at the end of it, where you do give the augmentin or whatever for that viral illness. So I think that that's also where it comes. So we sort of, it's not just antibiotic stewardship that we need to talk about, but also almost laboratory testing stewardship, because I think that it's easier for primary care to have that discussion with the patient without a positive micro culture in front of them.
Is there any way you can have like the patients that are long term? You know, like, is there a way of having like a baseline lab test for that patient, knowing what's their normal?
We do
knowing what's outside their normal.
We do that a little bit for the CF patients, but you can imagine there's not very many CF patients. So So we have in the laboratories, you might have a list of the CF patients that are known to that laboratory, but even doing that possibly breaches privacy. Do you know what I mean? So, but we do that because there are some things that can grow from CF patients that can be dangerous, and so they have to be kept in a different way, in plastic bags and things. I think the reality is that laboratory medicine is becoming increasingly commoditised in the way actually healthcare is becoming increasingly commoditised. And outside of the small peripheral labs, which will probably not last forever, we just can't offer that kind of boutique service because it's expensive. So when we see a result and it's sort of like, you know, the lab staff will say, oh, there's an ESBL in this urine, we'll go back and say, oh, what's this patient had before? So we do, but also we can't stop a lot of things because they come, you know, so lab test gets 13 to 1400 urines a day, Monday to Friday. It's very difficult to individualise that service, so it's like a conveyor belt.
If you look to just expand on ESBL, it's not a television station, is it?
No, it's it's not Fox News. No, ESBL, so extended spectrum beta-lactamase, producing what used to be Enterobacteriaceae, which I could not spell, and now it's Enterobacteriales, which is more spellable. So that's E. coli, Klebsiella, that's that sort of group of gut-based gram-negatives. So, you know, a little bit of antibiotic history, and I've got some slides we could read out later if necessary, but penicillin, when it was invented back in the 1940s, even at the time that penicillin was invented, the organisms already had the beta-lactamase, which is the gene that cuts the beta-lactam ring in the penicillin, so and stops the penicillin from working. And so within the first year of penicillin being used in people to treat infections, within the first year there was the first penicillin-resistant Staph aureus detected. And then we go on and we develop the other antibiotics like Fluclox, and then within the first few years of Fluclox being used, then you've got MRSA. So the ESBLs, they are gram-negative resistant organisms, and I did my physician's exam in 1999, I think, or 1998, and we just were learning about ESBLs, these, you know, very rare things, and there were a couple of cases at Middlemore Hospital, and now they are everywhere. So they are genes that basically encode resistance to all the penicillins, cephalosporins, often resistance to cotrimoxazole and Cipro, and so really all you're left with is the ertapenins, meropenins, so that the genes, they collect on a plasmid, and the plasmid is able to hop between different gram-negative organisms in your gut. So it's mainly in your gut. So you know with MRSA, we look in your nose and axilla and skin for MRSA. It's your gut that is where the ESBLs live. But they're very good at transferring the gene in between different organisms in the gut. And they're very good, particularly the Klebsiella, at spreading around the community. And there's evidence that if you live in a household with someone who's got an ESBL, then other people in the household might be carrying them as well. Much of the ESBLs came in from parts of the world, from Southeast Asia, India, those sorts of parts of the world where you go down this road and you buy your antibiotic. But now that they're here, and particularly the Klebsiella, they've spread very successfully around the community. Now, years ago, Susan Taylor and I did a study where we took feces samples that came into DML in Auckland, the community lab in Auckland, and so feces samples for whatever reason, C. diff testing, CAMPI testing, fecal occult blood testing, and we looked for ESBLs in those samples, and I think about 5% were positive. And that hasn't been replicated, but I think if it was replicated in Auckland, it would be considerably higher.
Do they check people routinely in hospital? Because a friend of mine went in with a crush injury of her foot, and she had an ESBL, and she got shoved into a room with somebody else who had ESBL. Yes. And would they have tested her for that routinely? Because I didn't know the history.
If you admitted into a ward, you wouldn't be tested routinely.
What do they test? Your stool or your urine, or what do they test? Okay.
But I don't think they test.
Swabs.
Yes.
Those are orthopedics or plastics.
Yeah, but they don't test. So it's people who've been in other hospitals.
Yes, they don't test everyone.
Yeah, they don't test everyone. People who've been in other hospitals, and people who've been in overseas hospitals in the last 6 months. And now, because there's a new organism, which is actually much worse than ESBL, which Middlemore has been having a few problems with, as well as some other places, called carbapenemase-resistant organisms. And so they can be genuinely multi-resistant and only colistin.
Goodness me.
And they are very promiscuous and move in between organisms in the person's gut, and also can lead to some terrible outbreaks. Again, unfortunately, arose in India and places like that. So now so the other day my husband, because we've just moved to Dunedin and he's an orthopaedic surgeon, and I was working from home, and he calls me and says, there's a woman who's just come from India a week ago, and she's in a 4-bedded room, and I don't think this is right. Because he's had that experience at Middlemore Hospital with, it wasn't prejudice against people from India, but and their rule was that only if they'd been in hospital in India, and then the microbiologist and the infection control nurse has reviewed it and said, actually, anyone who's come from India and is coming into our hospitals needs to go in isolation until they're screened. So we actually are probably going to end up doing more and more screening, but the screening is also very expensive.
A bit more complicated than you thought, isn't it, folks? Okay, so sort of to start back from the clinical point of view, Tim Keneally and I wrote an editorial in the BMJ about 12 years ago, just saying that acute bronchitis doesn't exist. And the old joke used to be doctors would have a patient with a common cold and they'd want to give an antibiotic, so they'd write acute bronchitis, RX amoxil on those old 6x2 cards or whatever. And if you look at and there's actually a Cochrane review on acute bronchitis, but if you actually look at the individual papers, the patients, you can see the patients in there, some don't have lower respiratory tract signs, so they presumably have a cold. Some do, they will have asthma, and a few will have pneumonia. Presumably they look too sick to get in these studies, although I think you get low-level pneumonias, and some will have COPD. You put a bunch of those people in a room and give them antibiotics, and you will get a small benefit. Nothing for the asthma, nothing for the cold, a little bit for the COPD, and a lot for the pneumonia. So if you pull the wrong people, so the review is flawed. There actually is no ICD definition of acute bronchitis. Some talk about cough with or without lower respiratory tract signs, but you can see it's a symptom cluster rather than a... Yes. And of course that's what you see as in primary care. You see a symptom cluster. They're not sick enough for a chest x-ray. You can't hear anything. And I often think in a primary care consultation, if a patient comes in with any respiratory symptoms, probably before you ask any more questions, you should stick their stethoscope on the chest. And I sometimes do this. So I just want, if their chest is clear, you want a note for work, I mean, literally you're out the door. It hardly needs much more after that unless you think they've got sinusitis or otitis media. But that's the key thing, if someone got a clear chest or not. And if they haven't, well, is it a bronchospasm or is it an infection? Okay, so, and the other thing is, in one of the papers, older people did better. And that tells me these were people with COPD who were getting better, who were called acute bronchitis.
You mean got better with antibiotics?
Got better with antibiotics, there was a benefit.
Comment was, some of the antibiotics that get used, like Rulide or roxithromycin and erythromycin, have an anti-inflammatory component, and doxy. And so it may be that actually the clinical benefit is partially due to dampening down of the immune response as well.
And so the issue is giving either antibiotics or paracetamol would be, and I'll just see what we've got in the book, just to check we're agreeing with ourselves here. So it's one of the very first ones. So it's a particular interest of mine. So don't go using it as a diagnosis unless you're trying to justify your giving of an antibiotic. And you mentioned Augmentin before. We're going to talk about the only two primary indications for Augmentin sometime today. We run an Augmentin-free clinic at our clinic at Greenstone, and you're not allowed to give Augmentin unless you get permission from somebody else. And I have a couple of famous stories of asking 50 medical students for permission, and they denied me permission. Because sometimes with children you give it for taste, because Fluclox tastes awful. But actually the BPAC guidelines are suggesting cefalexin now. And I know Dinny, who just passed, Dinny Lennon died last week or a week ago. She was the big rheumatic fever campaigner who'd been at rheumatic fever for like the whole time I knew her. She was just dedicated to eradicating rheumatic fever. She was a bit anti-cephalosporins because of the serum sickness-like thing, but that seems to...
I don't think... I've not heard of cases, but then I guess, yeah.
And the other thing, actually, the other thing I heard about the first generation cephalosporins is about a 10% crossover with penicillin, but the later ones, the second and third, it's only about 3%.
You mean with allergy?
With allergy,
yes.
Yeah, so, but of course we don't use the second and third generations really in primary care.
No, but also most allergy is nonsense as well.
Most allergy is nonsense. Do you want to say that louder?
Well, not being an immunologist, but there are some very good papers looking at penicillin allergy and looking at people who've come in with penicillin allergy. There's several papers that indicate that people that come in saying they've got either to primary care or secondary care and saying that they have got allergies, you know, have a history of allergies, they get more expensive antibiotics and less efficacious antibiotics, and sometimes they even have longer stays in hospital. So it's really important in primary care with any patients who have a history of allergy to actually try and sort it out. One of the difficulties for primary care is that it's hard to get those patients into an immunology clinic. So the immunology clinics will only see patients, I think, who've got multiple allergies or with bad things happening, or if they are the kind of patient that's going to need a prolonged course of something, so endocarditis or something like that, and then they will desensitise them.
I did my family medicine training at McMaster in Hamilton, Ontario, just as the evidence-based practice thing was all taking off from McMaster. And they used to have a clinic there where they'd take people with so-called penicillin allergy and put you into this little emergency room with a defibrillator and an anaesthetist and run penicillin, and just about nobody who was labelled penicillin allergic was truly penicillin allergic.
But still get patients coming through and they say, oh, my parents are allergic to penicillin.
Oh, right.
So therefore, my allergics are from their file because
that's
they
interesting.
present and they say, I'm allergic because my parents are. So then they become allergic
so
to penicillin,
interesting.
but they're not.
That's so interesting, and that's where we have to be much more critical as asking those patients for more information.
Yeah, it's not genetic.
Yeah. No. Well, there may be a genetic component, but also those parents got dirtier antibiotics, and so there was other stuff in the antibiotics.
And most of the labelling comes from children who have viral illnesses. They get the viral xanthum and they get given their amoxil, which they didn't need in the first place. It drives me crazy when I see that. I was just going to make the point, actually, I don't know if you're aware of how many people die in New Zealand of antibiotics. I thought it was 4 a year. It's probably about 1 every 2 years. But it's not from the hospital drugs. It's actually from the amoxils, the doxycycline, liver failure, bone marrow failure, erythromycins. When I started in practice, there were 10 people a year getting bone marrow problems from cotrimoxazole. Now, we don't see that these days because nobody... But I still feel twitchy about giving cotrimoxazole. I don't know if it's safer in kids than adults. I really am virtually, it has to be something pretty damn serious before I give cotrimoxazole. Yeah, there were a couple of deaths every year and bone marrow aplasias. We used to get these little reports from Dunedin.
I wonder if it was higher doses or if it was a different...
Well, everyone was getting it. I mean, urinary tract infections, but colds and, you know, it was used as much as amoxil, I would say, back then.
Oh, that's interesting.
So
they do use it, and you know they will use it in bone marrow suppressed patients and keep a close eye on things.
That's fine. You know, us in primary care need to be judicious. You know, I think you know the heavy duty stuff is fine. So just on page 1 here of your handout. So we just got going along there. Have you got a handout there, Arlo? There should be one in the book. Yeah. Chest X-ray, it depends if you can get a chest X-ray the same day. If you can't, you need to lean on your DHB. We can at Middlemore and get a report the same day, or do it privately. There's these urgent care type programs that most of you should have. If you don't, you should be leaning on your
But you wouldn't be doing a chest X-ray on everyone.
Oh, no. Just if you're thinking of giving antibiotics, you probably should be giving a chest X-ray.
Well, that's interesting, actually. That's a sort of...
Unless it's an obvious pneumonia, you know, but if you're thinking, you know, I'm not sure with this patient, sputum culture is not needed, which I think goes along with the music to your ears. I have patients coming in and say, my cough, I got a cough 2 days ago and it's now 5 days and hasn't got. Coughs take on average 3 to 5 weeks to go away. You have to say, I say to people, this cough may take 3 or 4 or 5 weeks to go away.
Are we allowed to, before morning tea, discuss 2 things?
Please do, you're the boss.
Okay, I'm not the boss. I was sort of the boss at lab tests in Auckland, but I'm not that yet. I'm a lowly microbiologist.
All right.
So I'm a bit of a loosey-goosey girl when it comes to being a doctor, and every so often a friend or a colleague comes to me and says, oh my God, this cough is driving me crazy. And I ask them a few questions, and then I give them a prescription of 20 milligrams of prednisone for 5 days. Is that naughty, Bruce?
No, I think so. It's my usually hospital colleagues are notorious for wanting antibiotics for their colds. They have no interest in colds until they get sick themselves.
But I'm giving them prednisone.
Oh yeah, no, I think that's okay.
They've got to. So I say, did you have childhood asthma? And if they say yes, then I give them prednisone.
Yeah, I think that's probably a safer option. I had a gem on the harms of short-term steroids. From the antibiotic stewardship, I'm really with you. Numbers needed to harm for a fracture about 800. And I'm going to give another personal story here. I broke my ankle on 40 milligrams of prednisone on the dangerous slopes of Mount Eden. I wish it was the death zone of Everest. But my wife and I were walking on Mount Eden, and I slipped down and my ankle went north, south, east, west, completely painlessly. Now, I've done the Hollyford track. I've done some heavy-duty tracks and never even sprained an ankle, and my ankle completely fell apart.
But was that after you'd been treated for the...
I was about day 4 on 40 milligrams of prednisone.
But had you had lots of prednisone leading up to that?
No. And this was short courses. In under 65-year-olds, numbers needed to harm about 800. Go back and have a look at the gem. About 3,000 for infection and about 3,000 for DVTs, for deep vein thrombosis. Short courses.
Steroids?
Short courses of steroids.
Okay.
But anyway, in your colleagues' cases, good to educate them that there's something they don't need antibiotics. I think. Give them what?
Ventolin, yeah.
Well, that's right.
Inhaled steroid.
Inhaled steroid too.
But I was just going to say, you need to check whether the patient wants antibiotics, because there's quite a bit of research of patients coming in not wanting antibiotics, and doctors, in particular, because there's been doctors who've been studying, thinking they do want antibiotics, and giving people sometimes just want reassurance. So I'm a big fan of the passive voice. So somebody comes in, I'm slightly irritated when somebody comes in with a respiratory symptom. I think, this is not a good use of my 35 years of training and expertise and PhD and whatever. But anyway, they're there. And is there something you are hoping I could do for you today? It just brings out, it's not sort of saying, well, what the hell are you here for, which is what's going on in my brain. It's just a nice way of camouflaging my irritation. But it does sort of get out, well, I just need a note for work. Well, that's easy. Out the door, like it's all over if that's the case. That's an HR issue. I think notes for work are an HR issue. Somebody vomiting and diarrhea, you say, how am I going to know? Bring in the specimens? I mean, God, no thank you. Yes, question?
Yeah, I was just thinking about someone I saw in the ED recently who wanted the antibiotic for acute bronchitis presentation because they had 4 generations of people under the one roof, so they're in a very overcrowded house, very poor, and their little ones have already been up and down with respiratory help in the hospital. So they came in, worked really well, but they wanted antibiotics because they didn't want everyone else to get sick.
Right. Except there's no evidence that would make any difference. Probably the virus that they've got has been shared with everyone anyway. Yeah. That's the problem. It's like the daycare problem, isn't it? Keep your kid away from daycare if they're sick. Well, the virus has already been shared days before. So, I'm sympathetic to that situation because it's, socially very difficult. But I don't think, the trouble is that is a group of people who are going to need antibiotics. And you start creating resistant organisms, and then you may have created a monster downstream, if they don't get better when they get an ear infection or something. So that's the risk. These are not candies. They kill people. And then the other thing is somebody comes, it's like the Tony Street thing. The only thing she was going to get from the antibiotic was harm. There's no chance of benefit. Right. Absolutely no chance of benefit. All she's going to get is either symptomatic harm, diarrhea and vomiting and rashes, and serious harms like liver failure, which she got, and then death. I've had 2 patients end up with liver failure from Wellington, and I don't see, it wasn't given by me, but from somewhere else, and that's the only drug I've ever on my watch that's ever done that. I've never. The most serious harms I've had from patients have been with Wellington, hence the desire. Then there were 1.4 million prescriptions in the year 2000. It's dropped down to 700,000. It's a massive amount of a very valuable antibiotic. I was just going to say, just in terms of PHARMAC give us no direction on what we talk about here, so they're not suggesting we promote something or not. They're completely neutral about it. They just want good, rational prescribing. So they don't, if you want to give an expensive antibiotic and you think that's the right drug, then they are right behind you there. So they're really interested in rational prescribing, so they're very good like that with all our work. So with the common cold, so I'm a Cochrane reviewer on that. There's this myth of secondary bacterial infection, and you mentioned it before, the green sputum coming up and the patient thinking, or the brown sputum. And my understanding is the green sputum is oxidised sputum. Is that correct? Like, why does it go green?
I don't know. I don't know. That's terrible. I should know that. How'd I pass my exams?
That's right.
But it is just... yeah, I've got... Don't you worry, I've got... But it certainly is not an indication that there's necessarily... There are bacteria there because there are bacteria colonising in the airway. It's the same as people who send in swabs and they say, it's Pseudomonas, I smelt it, I could smell it. But wounds kind of... Yeah, I don't know that you can smell Pseudomonas in a wound.
Big wound you can, big you don't imagine you can. It doesn't have a distinctive smell.
And
you see a big Pseudomonas infection on a leg or something.
Yeah, I guess, well actually the truth is we can smell it in the lab, so maybe you can, alright.
Yeah.
I take it back.
So in terms of treatment, nasal decongestants are an option. Xylometazoline, that's about $12 at the pharmacy, I think, isn't it? Or you can prescribe inhaled ipratropium for serious rhinitis. That's effective. The other one is oral pseudoephedrine, which is one of my favourite drugs, recreational drugs. And as you know, it has to be on a controlled drugs form. This is a most unfortunate situation. The methamphetamine that comes into New Zealand, even 5 years ago, was coming in 100,000 tablets being smuggled in. Not the 6 tablets I give to the local accountant. It does not get turned into methamphetamine. And unfortunately, to get that was made just by statute, I think. To reverse that's going to require an act of Parliament, and I don't think the New Zealand Parliament would want the bad look of making methamphetamine available on the market, which is unfortunate because you have to go to the front desk, get the controlled drugs form, write it in, scan it. You know, it's a whole performance, and then you forget to even write in the notes you've given pseudoephedrine. But if people want to feel better today, that's the only thing that'll make them feel better today. You want to feel better today, you need a decongestant, because the problem is congestion with these things. The evidence, there's not much evidence around NSAIDs and paracetamol. Vicks, or the vapor, it's called vapor rub ointment, I think is the generic name, in children has been shown, children over the age of 1 has shown to reduce, or give parents a better night's sleep, which is probably the key thing. For children to suffer anyway. And honey, actually, there's quite a bit of evidence on honey in kids. Doesn't have to be Manuka honey either, but actually probably amoxil's way cheaper than honey these days. So there are things you can do, and we have a little handout with about 10 things on common cold how we print it, and I go through it, and at the bottom it says antibiotics don't work. So you tell them all the things that can work, and then you hammer home you don't need antibiotics. And I find people are happy. Steam doesn't seem to make any difference. And nasal rinses in an acute situation don't seem to make any. There are randomised trials on that. It works in the steam rinses work in the United States, but not England or Europe or vice versa. So
Irish whiskey.
Irish whiskey. Any randomised trials on it? It just makes people forget the thing. Well, my father used to be a pharmacist, and they used to have whiskey for medicinal purposes only. Do you still have that? Alcohol for it. So you see all these bottles at home of Irish, Scottish whiskey for medicinal purposes only. Well, my view is you should get shares. Don't buy the stuff, but get shares in the company because it's $1 billion industry. And I must admit, I would like the pharmacist to have the evidence-based section and the non-evidence-based section.
But cough mixture with opioids and that works, doesn't it?
Not for common respiratory things.
It works for cough, doesn't it?
No.
It doesn't suppress cough.
No. What's the one? Dextromethorphan. There are as many trials for as against. The evidence very inconsistent, and it was worse than honey. Actually, it wasn't as good as honey in one of the trials. So.
And should you suppress a cough?
I don't think it makes any difference, quite frankly.
You've sort of been told that if you suppress a cough, they'll get pneumonia.
Yeah.
That sounds like nonsense to me.
No. It's like should you take anti-diarrheal agents when you travel overseas, and the gastroenterologists always used to say no, but then if you ask them personally when they travel if they take loperamide, they all take it, and I thought, okay. I mean, I think if you've got ulcerative colitis or Crohn's, it may not be the best idea, but I think if you're a normal human being and you don't want to get to Tokyo and get diarrhea, then I think I would take it, quite frankly.
Sorry, do you have it?
No, I was sitting on to a consultant in Christchurch, it's in private practice, and he mentioned about steroidal nasal sprays.
Yep.
Yeah, that it worked really well for reducing sinus surgery later on. And
We're going to do sinusitis. That is an alternative. Yeah, there are some trial evidence. The big problem is what did the patients have in those trials? That's the thing. Like, how do you diagnose sinusitis? And there's an official definition in the BPAC thing, and I don't think I've ever seen anyone with that. 10 days of symptoms and a temperature of 39 degrees.
Shall I tell you what my personal common cold cure is?
Please do. Evidence-based?
No one will approve, especially the medical council. Imivane.
Imivane?
Because all you need is a decent night. Yeah, Finnegan's not good enough for me. But all you need is a decent night's sleep.
Yeah, I'm with you on that.
Fair enough. I
And
think,
if you can take half an Imivane and get 10 hours sleep, which,
you usually do.
It's 10 hours less of a cold.
yeah, so, I think that, and the coughing and the sore, when you have a really sore throat and you can't sleep, Imivane.
And if the patient has got a very, very sore throat, a single or 2-day dose of steroids, actually. But I'd only do that, and it doesn't seem to matter whether you do a throat culture or not.
No, I wouldn't.
And most adults don't have strep, do they?
No.
Strep is a childhood condition.
And lots of them don't have it either.
No. We'll get onto that afterwards. Okay, acute sinusitis. Okay. Well, what is it? So most of the time in primary care, this is my view, is it's mainly viral, basically. Now, occasionally people get very, very sick. The son of a friend of mine ended up in Starship with an ethmoidal abscess or something, and was incredibly ill, and he was there for 2 months, and they drained it and did all sorts. So some people get very sick. So if you see somebody coming in looking very toxic, then remember the trials won't have included those people. They would have been excluded and given antibiotics. So
we had a case 2 days ago whereby a 54-year-old gentleman had diagnosed with sinusitis by the GP, refused to take any antibiotics because he was more homeopathic. And 6 days down the track, he hadn't gone to work, and so the boss went to have a look at, because he lived alone, and found him in a terrible state when he came in. His CT, his brain was full of pus. Oh. Totally.
yeah, so that's a situation that's tricky. But when you see somebody who's looking otherwise walking into the office, I'm going to talk about influenza later on because I have some funny stories about influenza. And one of the old criteria was it was more likely to be bacterial if you had a failure of decongestant. So a good dose of xylometazoline, which is very potent, or pseudoephedrine, if they've still got symptoms, then that's more likely to be bacterial. The longer the symptoms go, and I have to say, I can't really think of many people who've had symptoms for 10 days in my career. I don't know, other people may see it, but I don't. The intranasal steroids is an option. Has to be fairly high dose, and I can't remember what the dose is. I've got the paper at home, but higher doses than we'd normally use, so it really is putting on stuff. Nasal rinsing may work in these situations, but there's no trial evidence. It's 80% of patients in the USA get an antibiotic for this. I suspect it's up there in New Zealand. Green stuff coming out of your nose doesn't mean you've got a bacterial infection. Although having said it, sometimes if you've got a child and they've got green stuff coming out of their nose for 2 or 3 weeks, then maybe an antibiotic's worth trying then if you're getting sick of,
We use the sinus rinses, but our consultant puts a steroid in it as well.
Oh, okay.
And it
Okay, a
seems
liquid
to work-
steroid.
Yeah, it seems to work particularly well. So the idea is they snort it up their nose until it comes out their mouth. And I mean, it's, you can only really do it with people that are capable of doing it, because it's like when you're in a swimming pool and you get water up your nose.
Yeah.
Oh, no, yeah.
Very unpleasant.
Yeah.
It's very unpleasant, but you feel like you've done something
But
significant when you've done it.
They're so miserable anyway.
Yeah.
They will do it.
Just from the laboratory perspective, we do not accept swabs from people's noses, because whatever bacteria will grow is just what's up the nose. It's not necessarily what's further back there. So it's only ENT surgeon collected swabs that are cultured. And please don't send us snot.
What about swabs for staff, recurrent
Oh yeah,
staff?
that's staff. That's just from there. But that's where you say on the clinical details, you say anterior narrow swab, query recurrent staph. So
Yeah.
that goes down a different pathway in the laboratory.
Yeah.
But we do get little bits of snot or little dried, crusty things that someone's picked off. Yeah. Yeah. So,
It's like patients bringing in their samples.
yes.
At least with cameras, they can show you pictures. It's not quite so bad, is it? So most antibiotics for acute sinusitis are unnecessary. There is this so-called second sickening. Now, what I find interesting is everyone talks about the second sickening with massive confidence. As far as I'm aware, there's no empirical evidence of that. No one's actually really studied a large group of these people, doing all sorts of bits and people and re-examining them. It's an area, and I think it's possibly an urban myth. I'm just throwing that out there. So this is when you might give antibiotics. This is the BPAC stuff, greater than 10 days. Severe symptoms that last for more than 3 days, or worsening symptoms lasting after 3 consecutive days. So that's the sort of BPAC model. And I have to say, I mean, I don't see a lot of patients, but I can't really remember seeing anybody where I would put hand on heart and say this person had acute sinusitis. I've never had to send anybody in who I thought was seriously toxic. But you may have a different experience. You would have seen some people in hospital, I guess, very sick with.
No, not really, to be honest.
So there's a lot of urban myth, I think, about sinusitis. And of course, the patient got antibiotics last time; they want it this time, So that's a monster of a problem
I
too.
suppose it's reinforcing as well if they've got better.
Oh,
they would have
yeah.
got better
Yeah.
anyway.
Well, that's
Yeah.
right.
But, I got better so much quicker last time because of antibiotics.
And
That's
the
right.
last thing that was tried always gets the credit for the improvement in clinical. And also I think, the stories that we heard about very complicated patients with very bad complications from sinusitis. The reality is that anything can, what we're talking about is sort of 80-20 rule, or even actually 99-1% rule, aren't we really? But that's why we have to have clinical acumen, as Bruce said, because if someone looks sick, you don't, I'm following this pathway. Meanwhile, the person's, so there's always exceptions, and there's always some people who, for whatever reason, will get very, very sick. But that's not a reason to do. We can't practice medicine always aimed at the worst possible scenarios, because it would be crazy. It would be very uncomfortable.
There was this thing that you had to give 10 days of antibiotics, and BPAC have now suggested 7 days. There was a trial where they compared cotrimoxazole 3 days versus 7 days, and 3 days was as good as 7 days. And my guess, if you had a placebo group, then most people would have got better anyway. So when they have trials, 90%, when they X-ray people, I'm not suggesting X-ray people, and they've got the fluid levels and things, 90% of those people get better with antibiotics, and 80% of those people get better with placebo. When they've done those trials without X-ray and primary care, it makes no difference. So in the primary care setting, without some sort of diagnostic test. So it's a bit tricky. In terms of which antibiotics do you use, they suggest first choice is amoxicillin, second choice is doxycycline. Their third choice is amoxicillin clavulanate. I have to say I wouldn't. Doxycycline or cotrimoxazole, I think, would be reasonable choices.
Again, doxy sort of maybe got a little bit of an anti-inflammatory.
And I guess, would roxithromycin be another option?
The Rulide doesn't cover H. flu very well,
okay.
so that's why it's sort of avoided.
So roxithromycin versus erythromycin. I've had so much trouble with GI upset, and roxithromycin does seem to go down quite well. And there is a kiddies version now, 50 milligram dispersible. Does everyone know about that? So it is an option, because the doses that when you see for erythromycin seem to be massive, really. And 50% of people throw it up, so it's not much use if it's
really that much.
It's in the and people get a lot of I haven't prescribed raw erythromycin for probably 10 years now.